Well, I think we'll get started, folks. So good morning, everyone. It is my great pleasure to welcome everybody here to NIOAN 2022 as the chair of the Northern Ireland Obstetric Anaesthesia Network. And isn't it absolutely fabulous to be able to actually meet face to face? Who thought it would be that exciting to have a cup of coffee, pastry? How far we have come since the pandemic. This is our first meeting since 2019, and it's a very different meeting, so bear with us. We're having to do everything in new ways. This is a hybrid meeting, so we have lots of people face-to-face here at the Hilton in Templepatrick, which is brilliant. But we also have a wide audience as well on Zoom. And welcome to all of you people coming from exotic locations all over the islands, like Belfast, Dublin, London, Lisburn, everywhere. So welcome to you all. I think we're going to have a fantastic day, because diversity is a whole big thing about this, isn't it? NIOAN, we have at our heart the idea that we are part of a big multi-professional team on labour ward, and it's great that our audience is wide, both in number and in geographical location, but also very wide in the diversity of the people. So we have not just anaesthetists with an interest in obstetrics, but we also have obstetricians, we have midwives, anaesthetic assistants and other allied professionals who all are part of our team, because it's a bit like that saying is, it takes a village to raise a child, and we all know that it takes a very wide team to safely look after women in maternity services here in Northern Ireland and elsewhere. And it's lovely to see that you don't have to be from Northern Ireland to actually participate in NIOAN, and hopefully you'll get the flavour of it and join us again in the future. The diversity doesn't actually stop either in our audience. We have a fantastically diverse panel, and in fact, when I was coming up this morning, it occurred to me that actually obstetric anaesthetists are sort of almost outnumbered in the panellists today. We have fantastic talks coming to us from respiratory physicians, from a neurosurgeon, from a psychiatrist and from an obstetrician. And so it's great that teams that work together need to learn together. And in terms of learning together, if you wouldn't mind putting the first slide up for me, Roy. In terms of learning together, it's all about communicating and teaching each other as well. So we would love you to tweet during the meeting as well, and start that conversation. Just don't be part of it, initiate it, and just make sure though that you tag our handle at Anaesthesia Network, and of course the hashtag for the meeting is NIOAN 2022, so get tweeting throughout the meeting. As you can see, the diversity of talks is fantastic in our programme today. And one of the talks is on sustainability. And we're very keen on sustainability here in NIOAN. And that means that we are trying to reduce our paper usage, etc. So if I could have that slide back up again, guys, we're going to use some QR codes for you to access things. So we're just about to do this for you. In the next slide at the top right, you can see that QR code, and if you want to scan that, that will give you the programme for the day on your digital device. It will also have been sent out to you, by the way, on your confirmatory email. And the second QR code, which is below that and to the left, please use that. That is the code that will take you to the list of trainee presenters and their posters. And those posters will be displayed on this main screen through all the coffee breaks, and also in the large screen outside in the foyer where you got your coffee this morning. So through all the breaks, that will be there. And for those of you joining us on Zoom, if you just leave your live feed running, the slideshow of the posters will be running throughout the breaks. Just then to also just remind you that there'll be another QR code at the end of the meeting. It'll start to be displayed after lunchtime, and that will lead you to the Survey Monkey, which will be your feedback for the meeting, and also will give you a link to that all-important CPD certificate, so you get your points for turning up today. In terms of the interaction, we do want lots of questions and lots of interaction. This is a friendly, interactive meeting, always has been. So what we'd like you to do is use your Zoom chat function to give us all your questions, and that will be collated by the faculty here at the front, and then we will put your questions subsequently to the panellists at the end of each session. Also, those of you who are here in the room, you have two options really. You can either use the Zoom function again yourselves, or you can I would remind you though to have your volume turned down for that if you're in the room. Or of course there will be the good old school roaming mic for anyone who really wants their moment in the sun. So I will encourage you all to be interactive today, to enjoy today. It's a very multi-professional setup. A couple of very basic housekeeping rules then before we head on into the meeting proper. The first is the good old-fashioned one. Please put your phone to silent or switch it off. And also, if you are using the Zoom function today, please turn the volume right down off on your device, because it is quite distracting for speakers otherwise. And the final thing is that if there are no planned fire alarm tests today, so if the alarm goes off, you literally need to go out through these doors that you entered, across the foyer where the coffee is, and out into the car park, where anaesthetists don't stop to get a coffee on the way. I know I need to remind myself of that. And for all of you on Zoom, of course, if the alarm goes off in your house, you are burning the toast. So just to mind that for yourself. So without further ado, let's get on with this interesting programme for today. And I'm going to hand you over to Dr Neil McLaughlin, my consultant colleague from the Belfast Trust, who is going to chair the trainee session. And this is a fantastic crowd of trainees that we are going to listen to today. Fantastic learning. Give them your full attention. Over to you, Neil.
Thanks very much, Damien. So just, this is the first session, this is trainee presentations. Just a wee quick reminder of the structure. So the trainees will give a 10-minute presentation and then 5 minutes for questions at the end. We'll compile questions from Zoom, or as Damien said, if we need a roving microphone within the room, we'll do that. So to kick us off from the South Eastern Trust, we have Ashley McElroy. She's going to talk to us about implementation of an online training programme for midwives during the COVID-19 pandemic in the Ulster Hospital. Thanks, Ashley.
Thank you. Good morning, everyone. I'm going to speak over the next 10 minutes or so about a project that's been ongoing in the Ulster Hospital. This is the implementation of an online training platform for midwives during the COVID-19 pandemic. And this is a project I've been involved with alongside Dr Caroline Martin, Bronagh Mackay, consultant anaesthetist, and Lisa Robinson, the lead midwife educator in the Trust. Okay, so what I'm going to cover this morning is an introduction to the project, talk about how it was developed and what it looks like. Have a short discussion about the results of our feedback surveys, and then talk about how it's going to progress in the future. So as we all know, back in March 2020, the COVID-19 pandemic affected us, and it has had significant impact on healthcare, including medical education, with reduction in face-to-face education opportunities, with cancellation of conferences, courses, and simulation sessions, etc. We have noted that this has been a particular impact on New Start staff with regards to their induction to units. So as a result, we have developed an online education platform covering the midwifery management of anaesthetic interventions on labour ward. So this was developed using an online education platform, Page Tiger, which is an online publishing arena, which is ready to subscribe to by the South Eastern Trust. The modules themselves were launched in the middle of November 2021. An idea is that it's to be used as an induction for New Start midwives and as an annual update for current staff. And this is to just focus on anaesthetic interventions in labour ward. So in terms of how the learning works, so a short survey is completed prior to starting the modules, and this is to ascertain the confidence levels in the management of arterial lines, patient-controlled analgesia, both morphine and remifentanil PCAs, and labour epidurals. Currently, there are 3 video-narrated PowerPoint presentations to be completed, covering the arterial lines, PCAs, and epidurals, and these each last about 10 to 15 minutes. Following the completion of the online modules, there are 3 multiple choice question quizzes to be completed. And then a short survey will be completed at the end, and this is to ascertain hopefully the improvement in confidence levels after completion of the training. Each participant will get a certificate of completion for each individual module, and this has allowed them to put it in their portfolio for evidence of completion of the training. So have we look at how the actual platform looks. So this is a screenshot of the homepage. So everybody will have their own individual login. They register for the training using either their home or work email address. So the left side of the screen just shows what the course covers, and then there's the link in the pink box for the initial survey to be completed. On the right side of the screen are the links to the individual training modules, arterial lines, PCA, and midwifery epidural training, and their associated multiple choice question quizzes. At the end, the link to the post-education feedback survey will become live, and this can then be completed. So the pre-training survey essentially asks whether you're completing the module as part of your induction as a new member of staff or as an annual update. Then there are 4 questions asking how confident do you feel in the management of a patient with an arterial line, a PCA, remifentanil PCA, and a morphine PCA, and then an epidural. And these are rated from 1 to 10, with 1 being not at all confident and 10 being extremely confident. Unfortunately, I haven't been able to do any video clips due to file size, and wasn't sure whether I'd be able to get internet access here, but I've done some screenshots of the individual modules. So this is the arterial line management on labour ward module. As you see, it's a video narrated PowerPoint presentation, and it includes a variety of topics within it. So what an arterial line is, the equipment required to set up an arterial line, safety issues and potential complications surrounding arterial lines. There's a short section about the waveforms and what a normal waveform is, so that midwives can recognise what's normal and when they have to ask for help. There's also a section about how to zero the art line, how to take a blood sample, and then how to safely remove it. The PCA module is very similar. Again, a video narrated PowerPoint presentation. It covers what PCA is, the drugs that are used, remifentanil and morphine, and their basic pharmacology, safety aspects surrounding patient-controlled analgesia, what to do when a patient requests for remifentanil PCA, such as giving them the information leaflet, having dedicated IV access, contact anaesthetists. There's a section about what equipment is required, and then how to troubleshoot PCAs and when it may be necessary to call an anaesthetist for further assistance. The midwife epidural training module, again, is very similar, with covering topics such as what an epidural is, what an anaesthetist may want to know when you phone them requesting an epidural, so such as information about the past medical history, investigations, bloods, and what equipment needs to be gathered up to prepare for setting up an epidural. There's sections with regards to complications and potential issues with epidurals and how to troubleshoot them, and then how to safely remove the epidural catheter at the end. So this slide is just to illustrate what the quizzes look like. So there are multiple choice questions with a question with 4 or 5 different answers to select. They're true false questions. And after completing it, you'll move on to the next one. So the post-training questionnaire, again, has the 4 questions rating your confidence levels in the management of arterial lines, remifentanil PCAs, morphine PCAs, and epidurals. Again, it's rating your confidence levels from 1 to 10. And there's also a free-form text box at the end of this survey to allow for any feedback or any other comments that the participant may want to make. So with regards to the results of the questionnaires that have been completed so far, there has been a demonstrated improvement in confidence levels following the completion of the modules. If we break it down into the 4 individual topics, you see the arterial line average level of confidence has went from 4 to just over 8 out of 10, remifentanil from 8.5 to 10 out of 10, morphine from 6.5 to 9.5 out of 10, and the epidural from 8.5 to 10 out of 10. So it's not surprising that the remifentanil PCAs and epidurals have the highest level of confidence, either pre and post training, as these are the ones that are most commonly used in our labour ward, and the midwives are most familiar with them already. And just as a short discussion and summary of what the project involves. So the development of the online learning has allowed education to continue when face-to-face sessions have been limited. It can be used as part of induction for the new staff and as an annual update, and that'll be allowed to be, we can continue that on into the future for further education. It's very easy to access as it doesn't require trust internet access. You can use either your home work email, and it can complete it on multiple devices, your phone, tablet, and PC. And it's been very positive in terms of the survey results so far, with a demonstration of improvement of confidence levels. Unfortunately, there's only been a small number have completed so far, as it's only been ongoing for a short period of time, and thanks to COVID, everything has been delayed with regards to completion of mandatory training. But there's going to be a push over the next few weeks for this to be the next one to be completed. Lisa, the midwife, leading educator, hopes that this is the next module. There's about 120 hours actually for new staff to complete of mandatory training. So there's a bit of a backlog, and this is going to be the next one. And it's been circulated around labour ward staff via email. There's QR code posters, so it should be easily accessible for staff to complete. So this is just really a short run through of what the project involves. If anybody's got any questions, I'm happy to take them. Thank you.
That's great. Thanks very much, Ashley. Have we any questions from the floor? Any hands raised? No? Okay. So we have a couple of questions here. Just, you were saying that it's only really been implemented. There's only really a few midwives have been exposed to it. But from a practical perspective, have you noticed a change in behaviours since implementing it for those midwives who have gone through the programme?
Personally, I haven't. No, I haven't. I'm sure probably if chatting to ones who have completed it, obviously I don't know who has actually completed it, I don't list of names, but I'm sure they probably, as per their feedback, probably would say that they do feel a bit more confident in the management of these interventions on labour ward.
And, another question we have here is any reduction in calls to anaesthetics. It's the important thing. And any reduced adverse incidents?
Unfortunately, there's been no reduction in calls. Adverse incidents, I haven't noticed any change or any significance.
That's great.
Thank you.
Thanks very much. Any other questions at all? Nope. Oh, yeah.
Thanks very much, Ashley. That was great. I'm just wondering, hopefully as we move to being able to do a bit more face-to-face, how you think this fits in with maybe being able to be part of overall training? Do you think there's still a role for face-to-face training as well in these areas? So
the plan is that the new staff will complete the online modules and then do a face-to-face training, sort of covering a few of the different mandatory modules. And then as an annual update, you'll just complete the online training is what the plan is from the midwife educator point of view. Thank you.
Okay, so next presenter is Mark McCaig from the Southern Trust with his project Regional Anaesthetic Alert Bracelet.
So good morning, everyone. I'm Mark McCaig. I'm an ST4 anaesthetist, and I'm here today to present our project, which is on the Regional Anaesthetic Alert Bracelet, which is related to neurological monitoring after both spinals and epidurals. And this was a project implemented in the Southern Trust last year by myself and Dr. Rachel Mathers. So firstly, why are we actually doing this? Well, we know from NAP3 that permanent harm from obstetric central neuraxial blockade is in the realms of 1 in 170,000 cases. This, in some cases, can lead to devastating and life-changing injuries in a young patient population that, if identified early and leading to early intervention and management, can be preventable. Indeed, if you look at the cost of a person who becomes newly paraplegic at the age of 25, it's approaching the realms of 2 million, and that's before you get into the sort of the mental and the quality of life loss as well. So in response to all of this, and in relation to this, the OAA and the AAGBI released a safety guideline in 2020. And the bottom line of that is that they say that all women undergoing neuraxial blockade should have a straight leg raise assessed at 4 hours after either the last dose of spinal or epidural local anaesthetic. And if they cannot do this, an anaesthetist should be called to assess. So following this guidelines release, I performed an audit in the Western Trust back in 2020 and showed that no patients from a small sample of 31 had actually had this assessed at 4 hours. So we had a new safety guideline that I think everyone thought made sense and would improve patient safety, but we were not meeting the recommendations of that guideline. How did we do it? I can't take credit for the genius of the bracelet. That falls down to Dr. Mathers, but I helped her implement the project. And really this is in the form of bracelets for patients with stickers for application. So dedicated stationery was set up and kept in both theatres and delivery suite rooms. And there was education and approval at departmental audit meetings and education of our labour ward colleagues ahead of implementation. And you can see the sticker in the bottom right corner there, and it's a simple thing. It was applied onto a bracelet that represents a bracelet similar to their patient identifier bracelet. So how did we actually do this then? It's the beauty of this project is in simplicity. So in theatre, we have control of that as anaesthetist, and we write the 4-hour time for that patient on the bracelet. In delivery suite rooms, it's the responsibility of the midwife, and they document this 4-hour time at the time of epidural removal. And in addition to education and raising awareness in other ways, we put up laminated posters both in theatres, delivery suite rooms, and around the place, in addition to ongoing sort of chipping away at people and saying, do you know this is happening? Again, another real strength, I think, of the project is that it's simple, it's cost-effective, and it's patient-led, so it hasn't really led to an increased workload for any of the other stakeholders involved. The patient is educated at the time of the application of the bracelet as part of their expected recovery counselling. And simply, again, if the patient cannot straight leg write 4-hour time that they can look at on their bracelet, they remove the bracelet, dispose of it, and that is the end of the pathway. If they cannot do this, they alert their attending midwife, who contacts one of us with the bleep number provided on the bracelet itself. And then again, we're well placed to review the patient and say, and make a decision whether this is an important cause of delayed recovery or whether we think it's just something that needs a little bit more time. In addition to education and raising awareness, we were very wary about trying to implement methods that improved the compliance of the project. So we introduced some forcing functions, and these were mainly in the form of paperwork. So modification of the WHO sign-out for obstetric theatres to prompt bracelet application and documentation of time. And then for epidurals that deliver in the room, modification of the monitoring pro forma to include documentation at the time of removal. So this project was initially rolled out as a trial in elective sections in Daisy Hill Hospital, commencing in March 2021. And in the year following that, 630 elective sections were performed with a compliance rate of 100%. It was then moved on to emergency sections in Daisy Hill initially, and from May to 2021 to March 22, almost 300, again with a really good compliance rate. After this, it was then rolled out in Craigavon across all settings, including epidurals. And recently it was approved by NIOAN as a regional project and has since been implemented in the Ulster Hospital, Antrim Hospital, and I believe this week it's also just started in Altnagalvin. On the right-hand side, you'll see a picture of a letter that we submitted to the Anaesthesia Journal. It was published in January of this year, and it's amazing the interest that this has generated across the UK. I think everyone's had a similar issue of, know this guideline exists, but struggle to meet it in a way that doesn't increase workload exponentially for all involved. And it's the amount of emails I think that Dr. Mathers has received and Twitter engagement, and people really from obstetric units across the UK want to see if they can borrow this project to implement it elsewhere, which I think is pretty cool. We recently surveyed some patients at the time of discharge in the Southern Trust. So this sample of 30, all of them had the bracelet applied. All of them understood the reason why the bracelet was on. Looking at a reassurance scale of 5 being really reassured, the vast majority of patients were very much reassured by the presence of the bracelet. And also, I think of equal importance at the other end of the spectrum, no patients out of the 30 voiced any anxiety that was induced by wearing the bracelet. At the bottom in the free text, these were comments made by patients. I think these are all really reassuring as well, and it's interesting to see the perspective of the patient. They're saying things like, it helped me signpost my recovery. I felt like I wouldn't be forgotten about, and it encouraged me to mobilise earlier, which are all great things. So problems and pitfalls. No project is perfect. No project doesn't have teething issues. So on the left-hand side, we have perceived issues, which are the ones I probably had in my head before we started the project. On the right-hand side are the things that actually transpired to be issues. So time-consuming, we have busy days, and this is another, maybe perceived as a layer of complexity that takes time to implement, but really we are and we should be educating all of these patients about their expected neurological recovery. And this is just an additional few seconds of applying a bracelet and explaining its rationale. A major concern, I think, was, are we going to get a bleeping frenzy about patients with delayed recovery? And thankfully, we know from its prolonged implementation now in the Southern Trust across the year, really. We've only had 3 referrals off the back of these bracelets, and all of these patients, thankfully, have had a full recovery without intervention. Buy-in from stakeholders, so really the anaesthetic department and our labour ward team, has actually been pleasantly easy to achieve. It was universally approved by the anaesthetic department in the Southern Trust, and then I think our midwifery colleagues have been really pleasantly surprised again by how much they've engaged in the project, and I think they've really enjoyed learning about really what we do as anaesthetists, some of the techniques we use, and the complication rates of these. We know from the previous slide that it doesn't induce patient anxiety. So simple things trip you up. So changing trust documentation, changing the epidural pro forma and the WHO sign out were some teething issues that took lots of emails and time, but we got there eventually, and I think they've really helped to improve our compliance rate. Epidurals that deliver in the room, so we as anaesthetists have control of the patients in the theatre. That's our responsibility, but some patients can slip through the net if they deliver in the room, and I think the modification of the epidural monitoring form has been really important to improve the compliance rate of these patients that the midwives are responsible for applying the bracelet. Obtaining suitable stationery, finding a colour printer that works, bracelets are the right size, labels that are the right colour have been surprisingly difficult to achieve, but once you have a pack that works, it's actually very easy to procure that again. And sick patients and overnight, we are not perfect. We forget things sometimes. We have busy nights, we have sick patients, and I think it's important to bear in mind that we want the compliance rate to be as high as possible for this to improve our patient safety, but we are human at the end of the day, and we're going from a position where I think very few people are having 4-hour straight leg raise assessed to having much more than that, and I think any improvement that improves patient safety is a great thing. Another thing about this project, which I think is brilliant, is that it has scope for development elsewhere. So on the left-hand side, RA UK and British Pain Society. We know from the NAP3 data, if you scrutinise that, actually patients in these settings are much more statistically likely to develop neurological badnesses than actually the obstetric setting. So really, these patients actually might even benefit more than the obstetric population from a project like this bracelet. I think this bracelet encourages people to move early. If you move early, you walk to the toilet. If you walk to the toilet, you get your catheter out. And I think, therefore, it's well placed to form a part of an enhanced recovery pathway for elective caesarean sections. On the right-hand side is an infographic that was recently developed by Dr Catherine Shields in the Southern Trust, and we're looking forward to laminating this and getting it rolled out really across the trust that have the project implemented, just again to improve awareness in a user-friendly way. And at the bottom, as part of the same OAA and AAGBI guideline, they recommended that all units should have a policy for escalating patients that present with a delayed recovery, and that's something I think we all need to work on. So finally, to conclude, what are we actually trying to achieve here? What does good look like? Ideally, we would like this established in all maternity units across Northern Ireland with an auditable compliance rate and patient feedback helping to guide improvement of the project. We want to continue to brand the bracelet and create a pack that if other units are interested in rolling out the project, that it's much easier for them to take this pack and roll with it, and we can be there to guide them. We also want to collect data on patients who have delayed neurological recovery as a network across Northern Ireland. And again, each maternity unit should really have a policy that helps to guide the escalation of care of patients presenting with delayed neurological recovery. If I was to try and sum it up in one sentence, we want to eliminate all avoidable neurological consequences in the obstetric population that are due to delayed presentation or identification of delayed neurological recovery. That's the presentation over. I would like to acknowledge all these wonderful people who have helped along the way, who have helped to roll it out in different trusts and have helped engage in the project, and particularly to NIOAN for their help and support and approval of it as a regional project. I really appreciate it. If anyone has any questions.
That's great, Mark. Thanks very much.
No problem.
We have a question from Zoom here. Hannah Bodden, she asks, do you have any experience of using this in non-English speaking women? She says their patient population is predominantly not first language English, and language barriers can be a challenge.
I had a couple of cases in the Southern Trust last year at implementation. They have a wide range of patients presenting to that trust, and it doesn't make it any easier, but I suppose explaining anything about what we do in anaesthesia is difficult with these patients, and this is just another facet of that. And typically they do have their interpreter present either in the room or in theatre, that we can take our time if we're able to explain this project. So it is difficult, but within the realms of patients that don't have English as a first language, it's the same as with the rest of those difficulties.
Is there scope to produce a couple of other language?
Absolutely, yeah. I need a linguist to be able to do that for me.
Any questions from the floor here? No. I suppose, Mark, as well, just you sort of touched on other areas where it could be implemented. Yeah. Has that been pursued at all? For example, in orthopedics, somewhere where you would have high volume of regional anaesthetics?
We wanted to make sure this is well established in the setting that it was designed for, in the obstetric setting, first of all, but we are now starting to branch out into that. And actually, if you bring the slides up for me again, if that's okay. The infographic that Catherine Shields has really nicely designed has been submitted to RA UK as a sort of a patient safety type infographic, and we're hoping through that and engagement with RA UK that it might then develop into that setting, because, as I said, statistically those patients are a significant higher risk of neurological badnesses than the obstetric population, so they really would benefit from this, and we hope from taking baby steps with the engagement of RA UK that we might help to implement this across more branches rather than just obstetrics.
Thanks, Mark.
Thank you.
Okay, so our last presentation is from the Belfast Trust's Ciara Crail with T-trolley teaching on practical skills for midwifery staff.
Okay, so good morning, everyone. Today I've been asked to present a project that I did in collaboration with one of the other anaesthetic trainees, Sarah Henry, under the supervision of Dr Jane Wilkinson in Royal Maternity at the start of this year. So a bit similar to, I suppose, Ashley's project at the start, but ours had more of a focus maybe on trying to increase the practical element of it rather than online. So a bit of background. So as we all know, regular practical training is crucial for maintaining clinical skills on labour ward, in fact, in any clinical situation. As we all know as well, opportunities for face-to-face training can be limited. And this has been particularly following the onset of the COVID-19 pandemic. This has led to staffing shortages, and with those staffing shortages, there's been no reduction in the busyness of labour ward. It's led to social distancing and an increased reliance on remote learning. And we identified a need for more accessible face-to-face teaching sessions for midwives on Delivery Suite. And a lot of this need came from the midwives themselves, who came to us and said that they would benefit from more training face-to-face. The concept behind the T-trolley aspect of it actually came from this snippet, which was originally published in Anaesthesia back in 2014 by O'Farrell, MacDonald and Kelly. And they came up with the concept in response to NAP4's recommendation that airway skills are maintained with regular education and training for consultants and trainees. So what they did was come up with a T-trolley that had educational equipment on the top. So this was for sleep and awake fibres and needle cricothyroidotomy. And they had refreshments and tea and coffee as well. So they did the sessions that would last about 10 to 15 minutes. There was 2 anaesthetists per session. One anaesthetist would go into a list and relieve the listed anaesthetist out so that they could go to the second person and do a bit of training, get a cup of tea, and then go back to their list. So we thought to ourselves, could we adapt this concept somehow on Delivery Suite for the midwifery staff? Now, obviously, it's beyond my capabilities to go in and relieve the midwives from their staff or from their job. But we thought we would maybe get around this by liaising with a Delivery Suite sister to see if there's any way to get midwives out for 10 to 15 minutes to do a bit of training and then go back in. So the first thing that we did was initially survey the midwifery staff to see if there was what sort of topics they were the most keen to learn about. So by far, the 2 biggest topics that came out of this were management of arterial lines, both setting the arterial line up and sort of taking blood samples and looking after it, and also cricoid pressure. There were quite a lot of people who felt not confident about that. Other topics that came up, but not quite as frequently, were management of the critically ill maternity patient, CPR in pregnant women, and management of epidurals on Delivery Suite. So we set our teaching sessions up in the T-trolley style. And as you can see on the top, there's educational material, and on the bottom we have some refreshments. So the idea was to create this sort of flexible small group teaching sessions. It was fairly ad hoc and opportunistic. So what we would do is go to Delivery Sweet Sister in the morning, say that we were maybe keen to do a bit of teaching, and she would identify times of the day that she thought were the most sort of available to free up some of the midwives. Teaching sessions were short, so 10 to 15 minutes. So it really meant that whenever they were freed up, they could come out, get a bit of training and a cup of tea at the same time, and then go back to whatever they were doing. The teaching sessions themselves consisted of some objectives, a bit of theory on the skill, and we demonstrated the skill, and then all the midwives in each small group got to have a go at practicing whatever skill it was. We used questionnaires before and after to get some feedback as well, and also to measure their confidence. We measured competence by just using some questions during the station, and also just assessing their performance of the practical skill. So we spent a couple of months, this took place over about 4 months. So the first 2 months we spent doing arterial line management, and the second 2 months we used on cricoid pressure, and we carried out a number of teaching sessions over the course of those 2 months just to try and get as great a capture of the staff on delivery suite over that period of time. So arterial line management involved just learning how to set up an arterial line and also how to manage it on delivery suite, take blood samples and flush it and look after it. So before teaching, 71% of midwives knew the correct arterial flush fluid to be used, and this improved thankfully to 100% post-teaching. And all midwives were able to competently demonstrate taking blood sample from a mannequin. Now, when I say mannequin, it was actually Sarah Henry had a very good idea of filling a coffee cup with Ribena, cannulating it and attaching it to an arterial line set. So that allowed the midwives to have some hands-on experience of that. In terms of confidence, so setting up an arterial line and taking blood sample from an arterial line, the orange bars represent the confidence scores on a scale of 1 to 5, 1 being not confident at all and 5 being very confident. So the orange bars represent the scores before teaching, and the blue bars represent those after teaching. So if we look at setting up an arterial line, only 11% of midwives said that they were very confident, so a score of 4 to 5 before teaching, and that improved to 89% afterwards. Taking blood sample from an arterial line, only 7% were confident with that beforehand, and that improved to 82% afterwards. We then moved on to cricoid pressure, and to facilitate this, we borrowed a cricoid pressure trainer from one of the nurse educators in level 3, which the midwives really appreciated because they thought it was a good way just to get a hands-on and good feedback on whether their technique was good. So over 50% of midwives actually said that before this they had been asked to perform cricoid pressure in a clinical situation. But despite this, 65% rated their confidence with a score of 1 to 2 before teaching. Only 15% said that they were 4 to 5 confident beforehand. But after teaching, 65% reported their confidence to be high. And all of the midwives had a chance to practice the cricoid pressure on the trainer and were confident following this. So in summary, providing short T-trolley teaching sessions on practical skills is achievable despite the current challenges. And it was probably quite a simple concept, but it's something that we thought was quite effective, and something that was really highly received on the delivery suite by the midwives. Our managements demonstrate that there is improved confidence and competence in the management of ART lines and performing cricoid pressure following these sessions. And we feel that the flexibility and short duration of the sessions facilitated more staff attendance. And importantly, the cup of tea provided an opportunity to enhance relationships within the team, fostered a sense of well-being. And this is something which is really important in a time when levels of burnout are high and staff morale is low. It just allows, 15 minutes out of your day to come out, learn something new and get a cup of tea in the process. So a lot of the midwives said that they thought it was useful. They really liked the interactive component of it. They loved the cup of tea, and they were keen to repeat the sessions. So they were keen to do the same sessions, say every 6 months or a year, and they were also keen to do the sessions with different skills as well.
Thanks very much, Ciara. Have we any questions from the floor at all? Yeah.
Hi, Ciara. My name's Leah. I'm a midwife in the Ulster Hospital. I work at labour ward, but I only work at night. And your tea trolley thing looks really good, but is there any scope for it to be extended to night duty staff? Because I feel like we miss out a lot, and this is something that I'm really interested in, but I find I'm having to come in during the day on my time off, and you know, it's all kind of has to be pre-arranged and all that kind of thing. So is there any scope for, maybe I should probably ask Damien, because he's probably better positioned to answer, but I mean, is that something we could get going in the future? Because it's something I think would be really popular.
Yeah, no, certainly some of our sessions were done at night time, and the idea behind it is, you know, it's very basic materials. We literally had a drawer with some snacks and material that myself and Sarah had ready to go at any time. And certainly there were midwives who during the day shift when we did it missed the session because they were really busy at that time and came back to us and said, could we do this at a later time? And we just wheeled the trolley out again and did it again. But it's flexible enough to do at any time, you know. Obviously at night time, maybe if the anaesthetist is on their own and there's a lot going on, it can be harder to find the time to do it, but it doesn't mean it can't be done because it's there and ready to go. So yeah, certainly possible.
No, that's good to know. Like, even if we had to forgo the snacks, not proud of that, but I just want to know how to flush an art line without messing up. It's more important. Thank you.
Thanks very much, Ciara. I think the beauty of it is that it's accessible, isn't it?
Yeah.
Any other questions from the floor at all? Thanks very much, Ciara.
Thank you.
Thank you.
So that concludes the first session. We're going to take a quick coffee break now. I think we're back at 11:15, right, Sam? Is that the time? Yeah, I think so. In the meantime, I'd encourage everybody to look at the e-posters. There's a display out in the lobby there, and it will also be cycling on the live feed as well. So I encourage everybody to look at the further trainee poster presentation as well.